So I would like to thank Dr. Rohit for giving me this opportunity. So I'll be showcasing few cases. So first is this case. So everybody, why did we have an Argentinian flag sign here? So I would like to ask the panelists their comments, and then we can move on.
It's the intralenticular pressure
Okay.
plus the posterior push. So it's a huge.
Dr. Gaurav, what do you have to say? Anything else you want to add?
So decompressing small.
So you went from the main port and you were trying to create the
Yeah,
rexes.
that's right.
Yeah.
One more point, yeah.
So I would have just not used the main port for any instrumentation to go inside. I would have gone from a side port which was not allowing, and a heavy viscoelastic, maybe a soft shell kind of a thing to have good tamponer, and then I would have probably penetrated the capsule somewhere in the mid periphery where the pressure is the least, and then started maybe created a very small quick rexes there, and then aspirated some of the cortex from there, and then gone on to do the rexes again.
So this was a very old video with a very low ACT. So of course, as rightly Dr. Gaurav mentioned, it was a non-calibrated incision. So I had used a viscodispersive and I didn't do a closed chamber decompression. So ideally the AC pressure should be more than the intraventricular pressure whenever you are dealing with those cases. And in this case it was lower, so there was an efflux of OVD with the radialization. So how do we prevent it? So there are numerous ways, like preoperatively, whenever you have an intumescent cataract, you can see the ACD, which is usually low. You can compare it with the other eye. The lens thickness is more. And then, of course, with the preoperative anterior segment OCTs, as we are using it in all the white intumescent cases, we are able to plan it preoperatively. And then with the slit lamp examination, in biometry, you often see those 2 or 3 spikes. So the basic fundamentals are that in this intumescent cataract, you have compartmentalization. There is high intralenticular pressure. So it's there in the intumescent cataract, whereas in Morgagnian cataract, because of the freely mobile nucleus, so there is no compartmentalization. So there are less chances of radialization in Morgagnian cataract. So our aim here is to increase and equalize the pressure in the anterior chamber, and do not allow the AC pressure to decrease or suddenly decrease. Use calibrated incisions to prevent the efflux of OVD from the AC. So how do we decrease the posterior pressure? We can use IV mannitol, which can cause temporary removal of fluids from vitreous gel. You can use lid pressure like Jaffe speculum, which gives you less lid pressure. Use Hyalase to spread the anesthetic agent used for the block. People do dry vitrectomy also before in such cases, or you can do flax by taking the advantage of closed chamber decompression. So in this case, like what we usually do is we make a micro incision if possible, like a calibrated one. We can make a partial micro incision initially if you are doing it from the main port, or as Dr. Gaurav said, we can use the side port. So first step is do a 30 gauge needle decompression. So what we do here is a bevel down 30 gauge needle from the peripheral cornea. It is entered and it is taken into the central part of the lens, and it is decompressed in that area. So simultaneously decompression with the 30 gauge needle is done, and then you can see we have an intraoperative OCT. So you can see here how with the help of 30 gauge needle, you can see in the OCT the central area is being decompressed, and you can see that there is a fluid area in the paracentral part. So now, as we know that there is decompression in the central part with increased intraventricular fluid in the paracentral area, so our next step is to make a small central capsular rexus in the decompressed part. So with the initial nick through the calibrated main port, we make a small capsular rexus in the central decompressed part. So once it is done, so now there is still intralenticular pressure in the paracentral area. So how do you manage that? As Professor Chi has shown, capsule milking. So this is a very nice way where with the blunt cannula you can gently massage the paracentral area and you can take out the fluid through the center. And then after that, debulking and decompartmentalization is done with the same cannula. You go in and you aspirate it as there is still some amount of fluid in the posterior compartment. So you go in, you gently tap it, and you take out the posterior, the fluid from the posterior compartment. So now the incision, the calibrated one, is made, and with the gentle capsule milking, the remaining fluid from the paracentral area is taken out, and with the same cannula, it is aspirated. The remaining fluid is aspirated by a gentle tap on the nucleus, so that the remaining fluid, even from the posterior segment also, posterior compartment also comes. So now CCC enlargement is done, a nick is made, and you'll be surprised that all these capsules then they behave just like normal capsule, and you can make a normal 4.5 to 5 millimeter rexes comfortably. So another case where this is a case which was being done by one of our fellows, where he was trying to enlarge the rexes and inadvertently ended up into an anterior capsular tear. So you can see here there was, so as a flap motility sign, whenever you have an anterior capsular tear, and if the flap stops fluttering, you should be aware that there is some catastrophe which has happened. The tear has gone posteriorly, but the doctor, the fellow who was oblivious of the fact of the flap motility sign, kept continuing phacoemulsification, and the flap had stopped fluttering, and it led to a nucleus drop. So what was the root cause analysis in this case was there was an anterior capsular tear, and he was using high fluidics, which led to that anterior capsular tear becoming into a wraparound tear, and then the separational forces which was being used by the doctor were wide separational forces, and he was not aware of the flap motility sign. He should have stopped at that time and converted into an SICS or ECC. So what would you do when you have such a situation where the capsular tear has gone into an Argentinian flag sign? First plan is not to, you should not panic. Always evaluate the extent of tear using flap motility sign and use safe phacoemulsification techniques. So how do you evaluate the tear extent by flap motility sign is that everted and fluttering flaps are pre-equatorial in nature. But once this flap extends beyond equator, it stops fluttering and becomes inverted and becomes a wraparound tear. So that is the end point of safe phacoemulsification, that you have to stop at this time and convert it into an ECCE or SICS. So this case was a case of wide intumescent cataract which had an Argentinian flag sign. So how do you evaluate first? The first step is inject viscoelastic and see the motility of the flap. It is everted and fluttering, so this means it is pre-equatorial. The second step to evaluate is you can take your probe in with the fluidics. You can see how the flap is fluttering and is everted. So this means, this confirms that it is pre-equatorial. So how do you, when you are continuing the phacoemulsification, you have to continuously have a continuous vigil on the motility of the flaps. So you can do it intermittently, or what we do is we train our assistants, so they also glue themselves on the screens, and they see the motility of the flap, and because the most important thing is you have to see all the flaps, it's not only one flap. So what all safe phacoemulsification techniques you have to use is low IOP phacoemulsification, slow motion as being described by Dr. Abhay and Dr. Bob Washer. Then you need to have stable chamber settings. The site of incision, if you can make it slightly away from the tear or perpendicular to the tear, would be better, as it prevents any furthermore stress on the bag. Then you can create an additional rexus extension. There should be no pushing of nucleus while you're trenching or while you're doing sculpting. Avoidance of wide separational forces, and whenever you are using those separational forces, you have to use it in the direction of the tear. And if possible, you can also do a supracapsular emulsification. So talking about the prerequisites is, first is you need to have calibrated incision, whether it is side port or main port, because you don't want to have any fluctuations. Active fluidics, I have no financial disclosure, is one more thing, and then use of slow motion phaco is also very important. So aim here is to have minimal pressure difference between the anterior segment and the posterior segment, because if you have minimal pressure difference, so there's no pushing back of the nucleus, and the chances of an interior capsular tear becoming into a wraparound tear decreases. So what happens when you're using high fluidics? So this interior capsular tear, because of the high fluidics, there's an increased chance of becoming into a wraparound tear, whereas in low settings, the minimal turbulence and low pressure fluidics makes this interior capsular tear does not beyond the equator becoming into a wraparound tear. My machine settings, usually in these cases, I reduce my parameters, as Dr. Rohit also showed it before, with the low IOP of 20, low vacuum and aspiration flow. And for my quadrant mode, I slightly, if it is a hard cataract, I increase the vacuum and the power also. So coming to this case, so first is always remember low IOP, slow motion phaco, slow sculpting, slow division of the nucleus, which is very important, and separational forces should be non-wide separational forces in the line of the tear to prevent any stress on the anterior capsular tear. Slow rotation is very important. Aim here is to have a minimal pressure difference between the anterior segment and the posterior segment, so that there are minimal chances of this anterior capsular tear going beyond the equator. The minimal pressure, minimal turbulence and low pressure fluidics helps this anterior capsular tear in preventing going beyond the equator. And slow motion phaco is also another thing which is really important, which has to be kept in mind as described by Bob Osher. So in this case, the nucleus was a little on a harder side. So what I usually do is, because I usually avoid doing a supracapsular phacoemulsification in these cases, as patients, they really want to have crystal clear corneas and good outcome the very next day. So I use a small technique which we have published also, chopper shield, where we strategically place this chopper in front of the nuclear piece between the phaco tip and the endothelium, and we do a slow motion phaco with, so that there is less nucleus chatter and less damage to the endothelium. And with this, we continue phaco. Always remember to inject viscoelastic before taking out the probe, because that can also lead to an extension of the anterior capsular tear. And you can see here, I'm continuing IA with again low phaco parameters. And if I'm doing an IA close to the anterior capsular tear, I usually do a dry aspiration as by Gill's technique. The rhexis is regularized, and the one thing which I could have done was I could have placed the haptics opposite to the site of the anterior capsular tear. So thank you so much. So the last thing which I want to mention is that you can have a false positive anterior capsular tear also. So it is really important that all 4 flaps should be everted and fluttering, so you can take the help of your assistant, and you can also intermittently visualize the motility of the flap. And false positive flap motility sign is also seen in pre-existing PCR, so it has to be ruled out. Thank you so much.
I would like to mention about the flap motility sign, which the Rohit Prakash family have brought out, is fantastic, because it really is a great sign which can really save you whether you want to convert or not convert.
Thank you.
Thank you,